into that more with the knee, but there is a test we're going to do for the pelvis where you check the tens press lateral. Actually, I think we do that in the hip. Right, so again, now we're talking, we mentioned before you have static low back pain, and that's going to be from what? Well, not necessarily standing, only standing, but it could be sitting. You know, you should know well as anybody that you sit for a long time, that can cause you back problems too, not just standing. The main thing is it's static, the same thing, repetitively. It's not motion type injuries. So if you're standing a long time, what position is that going to tend to put the spine in more? More flexion or more extension? Extension. So what's that going to tend to irritate? So that's posterior parts of the spine. Okay. Sitting is going to do what? The reflection, that tends to aggravate the disc. So again, the static low back pain, like I said, it's divided into two kind of categories. If somebody talks about Williams flexion exercises, those tend to be for people that have problems with extension. If extension makes it worse, what kind of exercises are you going to want to do? Flexion exercises. And those are, I guess, somebody named Williams, right? So we say, hey, I got a great idea, let's do these exercises. So you're going to tend to have people do these, knee to the chest, this type of thing, rocking back and forth. So this Williams theory, basically, those are things that tend to be relieved by flexion. Then you're going to have the McKenzie school of thought, which is people have problems with too much sitting, too much forward bending. So what kind of exercises are we going to have them do? Extension exercises. So like with McKenzie, there's a protocol that they do where you, to evaluate the patient, you have them, you can either do it standing or you can do it different positions. You have them, you assess them to ask them, you know, where do you have your pain? Let's say, for example, they're having pain down the leg, right? And you have them do this extension thing 10 times. And then you ask them, how do you feel now? It's not so much whether or not the pain went away, but if it centralizes, like if the pain was in the calf, and they say, well, now it hurts up here. Does it hurt in your leg anymore? No, it hurts up here. So that's centralization, where the pain moves towards the center. So as somebody recovers from some type of condition like that, and the pain is moving towards the center, that's usually a positive sign that they're showing improvement. Right? So basically with McKenzie, the idea is they flex too much, so what are we going to do? Extend it. Where'd that go? Okay. So now we moved away from static, and we're going to talk about kinetic, and it's also called mechanical low back pain. You know, you see that a lot in a lot of literature and stuff when you talk about mechanical low back pain. So basically it's just things like lifting injuries, things like that, mechanical movements. So again, here we talk about mechanical low back pain, where it is to have a distribution of either in the low back centrally, or it will go down the back of the thigh. Often go down into below the knee. So if it gets down into that area, then you're looking at neurologic types of problems. Does that mean that if somebody has pain down the back of the leg that goes all the way into the calf, that you know for sure they have a disc herniation or a nerve root problem? Not necessarily. It just means it's more likely that it is. All right, so now we'll get into more specific actual conditions. Okay, so like usual, we'll start with acute injuries to nerve tissues and start with the bones. If you have some older notes, this isn't any of the older notes, you can have injuries such as compression fractures, where if somebody falls from a high, a couple floors up or something, they land on their feet, one of two things are usually going to happen. They're either going to fracture the calcaneus, or they're going to get a compression fracture. It could be a lumbar, it could be even into the thoracic. What happens, you can see here, is that the anterior part of the vertebra tends to compress. And actually this picture will work. See how if this is the vertebral body, and you have the spinous process back like that, the way that the trabecular run is like this, and so you have a weak area on the front of the spine, and that's where it tends to compress. So that's why it compresses anteriorly. Right? So somebody that has a compression fracture, if it happens in the thoracic, you've seen the typical osteoporotic person that's slumped forward like that. But if it happens in the lumbar, the anterior part of the vertebra is usually where it collapses because the trabecula are weaker in the front. Then you can also have a chance fracture or a seatbelt fracture. What happens if you have the seatbelt across the waist, somebody all of a sudden, let's say they have a high speed, say a head-on impact, their lower body is going to get restrained, their upper body is going to go forward, and it just shears the vertebra in half. So you can see how the fracture here goes through the actual vertebra. You're not going to see that too much, but it does happen. And now moving into the sacroiliac. So again, we're talking about traumatic injuries, tearing ligaments. So in the sacroiliac, you're going to have something like where they're falling, direct impact that's going to overstretch the sacroiliac ligament, or some type of thing that's going to force it into hypermobility, something where they twist or something and it just stretches those ligaments. Or you can have irritation of the joint, where the sacroiliac joint can get locked up. So those are the type of things, a lot of times people are going to say, my hip, I have hip pain, okay? But they're going to point right here. Is that really your hip? No, not really. Hip's down here. But a lot of times people say, yeah, my hip hurts. But a lot of times it's going to be sacroiliac. So that's going to be typically off to the side, not quite right in the center. You know, they'll be pointing right here to the PSIS. Okay. So again, the history is going to be some type of a fall or some direct blow onto that sacroiliac area where it's going to stretch or tear the ligaments. You know, they could have some type of a blow here onto the front of the pelvis that's going to force the anterior part of the sacroiliac. And so then they're going to have pain right on that SI joint, like I said. And then any movement is going to affect that area. They may have some misalignment of the pelvis. A lot of times when you're doing your evaluation, when they're standing, you can check and hook on the PSISs. Or when they're prone, you can check and see if one side is going to be rotated down. Typically, what we say like in chiropractic, we talk about the movement of the joints. You say that one side is PI, meaning that it's gone posterior and inferior. Because the movement pattern, just like I was saying with that nutation, the way the pelvic moves, is that the PSIS, if we're looking like this, is going to move posterior, inferior, and the other one will go anterior, superior. Okay? So you're going to look at the PSISs and see if one side is up or down. And they'll have tenderness in that area. They may have range of motion problems. And then the tests that we're going to do, when we show these, you have the straight leg raise, double leg raise, Gainsland's test, knee to the shoulder, anything that's going to stress that sacroiliac joint, either into, most commonly you're going to stress it into extension, but also flexion could do it as well. And then knee bending. This Patrick and Stinchfield's, those are hip tests, and we'll get into those next time. So again, you can have a facet sprain where you're tearing some of the ligaments. So again, if you have that faulty lumbopelvic rhythm where, in this case, they're extending the lumbar spine before that pelvic tilt, that's going to strain that facet capsule. So it's faulty lifting technique, and you have pathology of the facet capsule. So again, you're basically tearing that ligament there. Now in this case, when we talked about facets, we talked about facets are going to get compressed when you bend back like that, but when you bend forward, what are you doing to the facet capsule? Stretching.